As part of the aesthetics module, we're now going to talk about composite restorations. Initially, I'll be talking about anterior composite restorations, followed by posterior composite restorations, using the David Clark matrix system and the Bioclear method. Quite often, we all have composites that result with this, with the classic staining around the composites, failing due to the cosmetics. As we look closer up, quite often margins become very visible on restorations that were initially lovely to look at. We also, as a very big factor, have difficulty as dentists placing restorations on front teeth with composites that haven't got ledges or overhangs, as we can see on the slide here. Quite commonly, as we're going through checkups, we'll see these ledges which make very difficult staining, undercuts and sometimes gum problems. So as dentists, we would like to be able to place restorations that haven't got these defects. Quite classically here, another sign that you will see when you do composite restorations, and they've aged with time and they become stained. So our old school composites that the majority of us have been doing for many years are quite straight on the sides. As we see here, we have the matrix, which is straight, but nobody's teeth are straight. So ideally we want something a bit more curved. So the old school technique is you have your mylar strip, as we're all aware of, and that fits between the teeth. A wedge is then placed to try and get your seal at the bottom of the fillings. And then ultimately, we end up with the restoration, which is flat, but it gives you a black triangle, which obviously isn't cosmetic, and that's what we want to try to avoid. So, flat matrix system and a wedge ends up with a black triangle. We want to move beyond that and provide restorations that have anatomical shape to them. So we're going to go and look at a more curved shape that you can have. This is by using what's called the David Clark matrix system. This has been around in the United Kingdom since 2012, but has been around the world for the last 8 years. So what is it? It is again made of mylar, but it is only 50 microns thin, so it's very, very accurate and thin. And it's flexible, yet it is actually quite strong as well. But the biggest thing is the fact that it's anatomically shaped, and it is the only matrix system for anterior teeth that is anatomically shaped, that builds in that curve that is so difficult to build with the normal matrix systems. It gives really smooth, rounded shapes to it, and most importantly, overhang-free margins as well. So they're easy to clean, and it helps people's gum health as well. The 50 micron matrix, a rounded emergence profile, but it tightly seals against the gum, so it forms that seal in there, and it leaves a beautiful mylar finish, which is one of the most polishing and smooth finishes that you can have. The matrix system comes as a tower, as we can see here, and with the region that we're talking about in level 1, we're really talking about anteriors and diastema closure matrices. So as we can see here, we have areas where in previous restorations you have those horrible ledges that we get, trying to build in those contacts and the shapes. And then as we can see from the bottom slide there, the restoration after you've replaced it using the Clark matrix system. It gives a beautiful round shape, really nice. No overhangs, no ledges. So before with the ledge, and afterwards, nice and round. Okay. Even on x-rays, you're able to look back and you can see for yourself the ledges that you get with the old systems, the straight sides, and then when we have a look with the nice curvature afterwards that you get with the Bioclear. And it is the matrix that is doing all of that hard work in giving you the shape. So much better. That's what we're after. So clinically here, you've got the instance where you've got the shapes between the teeth. And these are the matrices, and as you can see, it's got that lovely shape to it, that lovely nice curve. It's going to slide nicely between the teeth, and you can see the space around the necks, the gingival margins of the teeth there, where you're actually going to be filling out that shape. Fantastic for black triangle closures that were nearly impossible to do with the flat mylar strip in the past. So before treatment with somebody with black triangles, and then afterwards when you've got that lovely closed area between the teeth. When we're using the David Clark matrix system, we also do something called the Bioclear method. The aim with the Bioclear method is that it's much less destructive to the teeth, so we're keeping things as minimal as possible, whether this be an anterior cavity or also with posterior cavities. If we're keeping things as minimal as possible, we're obviously going to be further away from the pulp as well, so that means you end up with less exposures, less requirement for root fill treatments. As time has gone on, theory has changed between leaving firm, slightly sticky dentin at the bottom of cavities. The most important thing with our cavity design is to make sure that our enamel junction is all clear, but trying to keep some of the enamel which we in the past would have removed. With regards to the margins of restorations, changing it from the old traditional bevels that we used to have into what we call the infinity edge, tooth restorative interface, TRI. We want to remove that white line that you get with a lot of fillings when we've placed them in the past, where you can see the transition between going from composite into tooth, and we end up with this white line. With the new design of margin, or the infinity edge, we've got a beautiful blend over it, so you don't get the white lines anymore. Most important, we don't want any biofilm left on the tooth, and I shall go through that in a minute. No staining with composites. In the past, as we could see from one of the earlier slides, we get a lot of staining on composites over time that sometimes require repolishing. Definitely no flat matrix. We want to go to anatomical matrices now, which give us that beautiful shape back. No kissy, or what we call point contacts. In the past, because we had to use a flat mylar strip, you end up with these point contacts between the teeth. Because you're having the anatomical matrices, they come up and they give you much broader contacts, much better, much less food trapping as well. No black triangles, which we showed with the matrices, and no post-operative sensitivity that used to be a significant problem with composite restorations. So, different approaches. In the past, we classically cut what we used to call a black cavity design. Suitable still for amalgam restorations, yet for composites, it's a completely different material. So we want to be as minimal as we possibly can. Emphasis more on blasting away any of the biofilm, adding to the tooth, and trying to keep as much of the enamel as possible. So aiming much more towards minimal intervention and additive dentistry. The margins in the past, especially with anteriors, we would look at traditional bevels or uneven bevels and trying to spread them out to get that blend. Now we're going to be looking at the infinity edge restoration, much better. Very, very important, we want to remove the biofilm. Lots of staining is caused by the presence of biofilm. Layering is very much a strong technique that's been used for many years, especially in Europe. We're going to be ending up going towards what we call injection moulding, heating the composite and injecting it into the cavities, so you end up with a dense, solid amount of composite. There's no air bubbles, there's no layers within it. And because of that, you end up with a much, much higher strength of the material as well. And also we're going to spend a lot of time looking at the shape of teeth rather than actually matching differences in shades and translucency. So why do composites fall short of the mark? Several things. Some of it's the wrong technique, okay, and we'll go through, as I say, comparisons between layering and going towards injection moulding. The wrong composite, different materials. The wrong finishing, and we have an excellent way of finishing composites here. The wrong matrix, going from something flat into something that's anatomical, okay. It's pretty much a lot of what we've been taught. So we're going to start a bit fresh today. Most essential, removal of the biofilm, blasting it instead of cutting the teeth down if we can. The infinity edge margins, really blending from one into the other, all right. Injection moulding instead of layering, as we've all been doing, and really look at the shapes of teeth rather than the actual differences in shade. So, going back to some of the first slides that we had, why do so many composites have those brown margins that we see? We finish the composites off, and then when people return for their checkups or future appointments, the brown lines come in or they stain. This is the composite that was taken in 2009, and this is 2013. It's the same composite, but as you can see, we have the stain running down there. So why has that formed? As some people put it, it's the root of all evil in dentistry. Everybody's mouth and everybody's teeth are covered in biofilm. It is a layer of plaque that lives on the surface of the tooth. If we leave that in place there, several things happen. First of all, your bond strength with your composites is not as good, and it stains. So, staining from the biofilm, as we've seen on that composite that was there. If it's the case that we don't remove it, as I say, the staining will definitely happen. So how do we remove the biofilm? In this instance, what I would recommend is the fact that you dry the tooth, you disclose the tooth, and you'll see all the plaque that turns up on the teeth that's there. What I use is a blaster, and literally we blast away anything that shows up with the disclosing solution. And you repeat it because you'd be very surprised at how much biofilm still remains even after you've blasted it once. In the past, people would think that by etching the tooth that you remove the biofilm that way. That is not true. The biofilm will still remain there. So don't be reliant on your etch to remove the biofilm. Some people don't have the facility of having a blaster, in which case, before I had mine, I used to use a really fine finishing diamond burr and very gently run it over the surface of the tooth, so as I'm making sure that I am removing the biofilm from the tooth before I do the restorations. This is the BioClear blaster. This is the one that I use. It attaches onto the fast handpiece, onto the coupling, and then we can use it straight away. Quite handy, quite straightforward to disinfect as well. So the area quite often where most biofilm is between the teeth, which we could see when we saw the pictures of the composite where it was stained on the margin that was there. Also, if we have people who have black triangles, etc., and want to close those areas there, that's the one area that you're going to get all of the biofilm in. As we can see from the disclosing solution, it's really thick in between the teeth, okay? Even after 15 minutes, when you're going through with normal prophylactic techniques and hand scaling if you need to, you've still got some of the biofilm that's there. So it really must be cleared away. And it's very hard to see unless you disclose it. As you say, after traditional techniques, the biofilm, the majority of it, is still unfortunately there. After 5 minutes of blasting, it's gone. And this will make a massive difference, not just to the cosmetics and the staining, but also to the bond strengths and the success of the restorations that you put in place. So that's what we want, this beautiful clean surface. You'll also find with the blaster that it actually affects the surface of the enamel, so that's why you get the better grip with the bond as well. There are other areas that can also remove things like biofilm, and there's different systems that you can use with regards to the hygienist as well. But for me, because I just do restorative work, the blaster is better for me. However, you would only want to be using that on teeth. It is not suitable to be using around any of the gum areas. So pre-biofilm, after blasting. So it's really important, and it's the same anywhere. Anytime that you're doing a restoration, an anterior or a posterior, you still must remove the biofilm. It's a really key pillar almost of being able to do restorations with composites. Other applications, such as with roots. So obviously if you're looking at re-cementing a crown or anything else like that that's been out of the mouth for a period of time, obviously the root surface is going to have the biofilm on it. So therefore, with the blaster, you've removed it all, it's nice, it's clean, you're going to get a much better bond strength when you're either putting a new post crown in or re-cementing an old crown as well. Quite classically, as I mentioned just briefly, when we're looking at posterior restorations, really classic, that line around the margins where your restorations are, and I'll go more into detail in that in level 2. But this is very, very common, but we can eliminate this by removing the biofilm and using different cavity designs. So as we were saying, first of all, we blast the tooth to remove all the biofilm. When we're planning for our composite restorations, traditionally we'll always look at the shade of teeth. I'll generally always take the shade of the tooth before I begin. Reason being is once we're working with the tooth, there's lots of air that we're blowing, there's lots of water, there's dehydration of the teeth. So the colour of the enamel and the shade of the tooth will change quite drastically, especially if they have areas of fluorosis on their front teeth. So traditionally, once the tooth is all isolated, before I blast the tooth, I'll take the shade record and give that information to my nurse. At that stage, the tooth hasn't been dehydrated, so it gives you a true likeness of the shade. And when you're taking the shade, you're looking at the body of the actual tooth itself. In the past, we would select the shades, plural, because we would be layering our composite, by the area of the tooth. So quite often you would have a neck shade, a body shade, a tip shade, even in detail like the translucency around the necks of the teeth and if there's a halo, etc. So we would try and match the colour of the filling with the area of the tooth that we were doing. All right. After polishing, quite often you'd find that the shades don't quite match up exactly as well. With the Bioclear method, it's very different. You take the shade literally from the body, from the centre of that tooth, and most of the time it will be a single shade. Now, a lot of people will sit there and question that because it's very different than anything that we were taught. With regards to a single shade, it would be the case, well, how can that work? Because your neck will be different than the tip of the tooth. However, because of the margins and the shapes of the cavity that you are doing, you get a much better blend with the actual shades of the tooth and the filling. You get a much better finish with the polishing system as well. So there's an awful lot more forgiveness if the shade isn't exactly right. And trust me, it does work very, very well. In traditional forms of composite, as I was saying, we'd have lots of different shades. So classically, you'd have probably about 3 different types of what we used to call packable composite, and then you'd also have your flowables. But now, because we're looking at a single shade, we can get rid of an awful lot of the older composites that's there. So we've got much less that we're having to use, and it makes the whole system much more straightforward, which also means you generally have to have less stock as well. So a bit of a bonus as well. So much, much simpler. So we're looking at the body shade of the tooth rather than the individual detail around the tooth. Heating composite. With the Bioclear method, we use what we call injection moulding. Again, very different. In the past, we would layer our composite. So in very tiny little increments, layer on layer on layer. With regards to the Bioclear method, you literally inject what we call the paste composite, not packable composite, but paste, because logically composite is a fluid material. It's very different than amalgam or anything else. It's a fluid material, so if you try and pack it in, or as we called it, packable composite, it tends to stick, and so it wants to lift up. So we want to inject it in so it's nice and solid. Why would you heat the composite? To make it injectable, all right? It flows up to 10 times more, so it gets into all those nooks and crannies. Nobody, no matter how good they are as a dentist, has the most perfectly smooth cavity shapes, all right? So it's very difficult to get your composite to adapt exactly to the side and the shape of whatever cavity that you have. By injecting it, if it flows in better, which it does when it's heated, then it will flow into those nooks and crannies much, much better, all right? So, enhances the marginal integrity. What's that going to do? You're going to get a better seal on your composite, which means ultimately you've got a much lower risk of secondary caries afterwards. So that's good, okay? By heating it, it also increases the conversion of the monomer. So it cures better, so it's stronger as well. It decreases the curing time, all right, which is reliant a little bit on your lights. So you must check your lights when you're using them as well. It improves the depth of cure, which is good from our point of view, because if we're injecting in, ideally with composite, you want to have the least manual manipulation of the composite that you can have. Because every time you touch the composite, every time you lift your instrument away, you'll just be dragging it back a little bit and lifting it away from the actual restoration. So ideally we want to touch the composite least possible. So we want to cure it in, and if possible, if we can get a better depth of cure, that means there's less intervention, less layers as well. You'd have thought, with regards to heating the composite, that actually it may have the effect of damaging the pulp inside. There's lots of research. Some of the slides I've got references on, and there is no history relating to the cause of pulpal damage relating to heating the composite. To be fair, as soon as you take the composite out of the heater, it decreases temperature quite rapidly. So you've got to be quite quick with that, all right? It also doesn't, by heating the composite, change the shade of the composite or any of the surface textures. So there's some of the references there. If you wish more information, please let me know on the course days. Different types of heater. There is the BioClear heater that heats the composite up to 70 degrees, which is very hot, all right? With regards to that, it makes it more flowable, okay? Warms multiple compules. You can put little compules in or syringes. I'd suggest to use the little compules, and you can put the same compule in more than once. Important if you do use syringes of composite that's there. Compatible with most composite either tips or shapes, etc., depending on the composite that you use. And basically plastic syringes ideally are better than metal just because of the heat. The composite heater that I use at the moment is the Mycerium one. It's been around for quite a long time. There's 2 temperature settings on it, and I always have mine at 50 degrees. Always have it nicely heated up on the side, okay? Ideally, as I say, composite compules are better there, and again, still with the plastic syringe that's there. Time for the matrices. We're going to look at the 2 types of matrices that were involved with the front teeth. Anteriors, logically, and also diastema closures. A diastema is a space anywhere in the mouth. We classically think of a diastema as the central diastema between your 2 front teeth. A diastema is actually, the definition of it is a space anywhere in the mouth. So there are actually diastema closures as well for your premolars and for your molars as well, which I have used. Okay, so these are generally the questions that you'll look at when you're choosing your matrices that are there, okay? How much space needs to be closed, i.e. for a black triangle, or whether you're just doing a straightforward filling around the centre of the tooth. If there's more space to be closed, then you'll generally tend to steer more towards a diastema closure matrix. If it's just a regular cavity shape that's there, you'll probably be more in the anterior zone, okay? The size of the tooth. With the matrices, they're very much built on whether they're in sizes, whether they're small or whether they're large. So there's a big variety of shapes as well that's there, okay? How much curvature do you need in the incisal half of the tooth? When we actually think about the anatomy or the shape of the teeth, especially something like your front tooth, you'll notice that the mesial, the middle part of the tooth, is generally more vertical. When you're looking at the distal aspect, it has an awful lot more curvature to it. So logically, if we're looking at anatomical matrices, you'd choose different matrices for the different sides depending on the amount of curvature that you need, okay? If we're going to be moving the teeth forwards or backwards, let's say if there's a crowded case as well, when we're looking at things like canines or premolars as well, the shapes that you're trying to replicate there, all right? And also when we're having a look at exactly where the papillae comes down as to whether we need to trim or whether we need to adjust the matrices. These are 2 pictures of the actual matrices themselves. On the left-hand side, you'll notice there's the anterior ones, okay? These still have their curvature, but they don't build out and close the space as much. On the right-hand side, which is the green tower, you will have the diastema closures. They build into that space between the teeth much more. And if we have a look, you'll be able to see on the right-hand side, where it emerges from the gum at the top, it then builds out. So there's almost like a gentle rounded shelf that builds out. In the tower is a selection of matrices for the anteriors. So these don't close spaces particularly. As I was explaining before, the top one is the mesial, where it's more vertical in shape. The second one down is the distal. It has more curvature to it. Third one down is generally the small size. That's absolutely superb for things like lower incisors, where obviously there's a much smaller size tooth than the front one, and also lateral incisors. Coming further down, you've got ones with more shape and more curve for things like your canines. This picture would normally scare me when we're looking at trying to do it with a mylar strip, because when you have a look at that cavity, one, it's curved, so you know that if you had a flat mylar strip, that would be an absolute nightmare. You probably can't get the gum to seal either, so you're probably going to get a bit of bleeding going on as well. Trying to get the seal at the bottom of that, you'd have to use a wedge, which means you're going to get a black triangle afterwards. All of those problems have been solved with the shapes of the matrices that you can place on it. The matrice will slide underneath the gum. The gum then forms a pressure against the matrix that then forms your seal at the bottom, henceforth alleviating any ledges or any overhangs. Because of the beautiful mylar finish on the actual matrix as well, and the shape of it, you don't have to do any finishing between the teeth, which is the one area that as dentists used to be a nightmare to try and finish. It is almost impossible to try and shape the composite after you've placed it, even with the finest burr, without cutting a notch into it or putting a ledge back into it. But the matrix does it all for you. So the only areas that you've got to be finishing are on the front of the tooth and on the back of the tooth, the areas that we can actually access and really polish up as dentists. So, as I say, in the past, that would make me quite scared on that side. That's classically an anterior distal matrix. So it would be the second one down in the pink tower, A102. So it's got more curvature to it. Okay. The green tower, the diastema closure tower, is very similar again in the sense that the top one is for a mesial diastema closure. The second one is the distal. The third one down is the small one, all right? And as you're working down, it actually brings into play things like your premolars and your molars as well. Times when there's quite a big distance in space between the roots of the teeth, even on back ones, and you're having to build them out. Very difficult to do, especially with sequel bands. DC201, naturally for your front one, between the mesial aspects. DC202 would be for the distal aspects of that. And it's labelled all on the actual pots that hold the matrices, so you'll know which one's which. Central diastema closure, as we can see with those ones, you'll be using the top tower on the green one, the DC201, because it's a mesial side and it's a diastema closure. With some of them, you'll notice on the slide here, there's a little pink line that runs along the actual matrix that's there. One matrix does not fit everybody, so you will need to trim the matrices, and you'll do this generally probably for about 60% of cases. However, David Clark does it on about 80% of his cases. It's important that you get the correct trimming so it seats correctly and gives you the correct shape, and I'll go through that with you. They also have matrices for the extreme diastema closures. I've not used one of them yet. However, when we're doing the practical course, you will be doing an extreme diastema closure. Black triangles. At the centre where we are here, there's a lot of people who are referred in for gum disease. And with regards to that, quite often as a result, once the gum disease has been treated, we'll end up with black triangles, which a lot of patients find quite unfavourable. They really want to get it fixed. In the past, you wouldn't have wanted to because you didn't have the matrices to allow you to do it without creating ledges and overhangs. Whereas now we have the correct matrices that we can close these. So again, with those, sometimes it's the diastema because you're having to build into that big triangle that's there. Also, with regards to reshaping something like a small peg lateral, traditionally sometimes you'd either be trying to do it in composite, which is very, very difficult, or you'd look at indirect restorations, which would be more destructive. With regards to the David Clark matrix system, the matrices with the correct selection allows you to completely reshape this, and we do this as part of the practical course as well. Okay, so on that side, you know you've got to build out the back of the tooth. It's a small tooth, so I'm not going to be using the first two of the matrices there. So I'm going to go for a small one, a diastema closure one to really build out the back of the tooth, and then a smaller one at the front. That's them in place, and you can see how you've already got the curvature and the emergence profile really nicely there. Injecting it all and then fill it. As I mentioned, trimming the matrices. Very important. What you would like to do is when you actually seat the matrix, you don't want it to jump back. If it jumps back, it means that the extension below the gum is too far. So when the actual filling emerges, it's going to be too high as well. So in that case, what you would do is you would trim it. The amount that you trim it by depends on the shape of the papillae. So if we bend over the matrix, as we have done here, or nearest to my side here, if you bend it over, if you have something like somebody with a flat papillae, somebody, let's say, who's had gum disease, then you'll be wanting to trim it across, but at quite a low angle. If you have somebody who's very young, who's got a nice triangular papillae, nicely into there, then it will be a higher step of curve. So you would cut it across the side. And then once you reseat it, it should sit down without jumping back and just nicely slide in. Other types of equipment as well. So these are some of the parts that are used with regards to the David Clark days and the Bioclear Method days. With regards to instruments, there are composite instruments as well. I've used some since about 2002, and they have different coatings, Teflon coatings, plasma coatings, and there's now the newer anodized aluminium coatings as well that's part of it. With regards to that, the aim of them is the fact that they have such a surface to them that they are less sticky when you're trying to place composite. Obviously we're injecting moulding, so therefore we're having much less contact with the instruments than you would used to when you were layering composite. However, it does make a difference, and it means that you get just that little bit less tug back when you're trying to either seat or flow almost on the composite there. We'll have a chance to use those again on the practical days. There are a vast array of different shapes. Every clinician is unique with what they like in the shapes of the instruments that they use. So it's a case of really finding some that you like to use and the shapes are compatible with what you do on that side. With regards to wedges, generally with the wedges systems, the wooden wedges we use a lot for posterior composites, but we can always use them for the anteriors. There are the sabre wedges, and there's also the diamond wedges that will be coming out as well. And they're lovely because they've got a bit of a flare. So they also, as well as holding your matrices in place, will also give you a chance just to separate the space between the two teeth a little bit more. So therefore, once you've completed your restorations, they come back and you get a better seal between the teeth as well. It's very important with any of the David Clark matrices, whether you use them on the front teeth or the back teeth, that you ensure that your contact points are clear between the teeth. If not, the matrix won't slide through. With these ones, they have what we call the easy strips. The blue is basically smooth on both sides, but it's got a little saw to it, so it can nicely slide between the two without actually changing the contact surface of either side. And then the red and the green one have a rough side to them as well, so you can expand the contact space if you need to a little bit between. Very important, always make sure that your contacts are free before you try using the matrix systems. So that completes the theory for level 1 composites.